Welcome everyone to the webinar on employing eHealth solutions in fragile settings. I am Maria Al-Kusa, the GHI Academy Division Manager. The Academy is the capacity building arm of the Global Health Institute at the American University of Beirut. This is the first installment of GHI's eHealth program webinar series on the role of digital health in strengthening health systems, applications in low and middle income countries. The webinar will be delivered by Dr. Shadi Saleh. Dr. Saleh is the Associate Vice President for Health Affairs and Founding Director of the Global Health Institute at the American University of Beirut. He is Professor of Health Systems and Financing and serves as Chairperson of the Department of Health Management and Policy. Dr. Saleh is also the Co-Director of the eHealth program at the Global Health Institute, which mainly focuses on digital health solutions to reduce inequity and enhance access to health services in low-resource settings. Dr. Saleh led the first eHealth research project in Lebanon, working with the Ministry of Public Health and a network of primary healthcare centers to improve access to healthcare services among vulnerable communities. Currently, he is leading a project on integrating gamification and artificial intelligence and strengthening mental health services among disadvantaged populations. Dr. Saleh has published over 100 peer-reviewed papers and commissioned reports and serves on the editorial boards of leading health systems journals. He also serves as a World Bank, WHO, and a UN advisor for healthcare financing and system strengthening. Dr. Saleh's webinar will be followed by a 10 to 15-minute Q&A session. So I encourage you all to type in your questions as he moves along the presentation. Dr. Saleh, handing it over to you.
Hello, everyone. It's nice to have you all join the webinar. As always, there are technological challenges. I assume that everybody has lived through that, and I think we're good to go. So I'm happy to start this webinar series with the first webinar on employing eHealth solutions in fragile settings. And as Maria said, the later part of the webinar would involve a Q&A session. So basically, we're going to discuss fragility, definitions, and some global figures. We're going to talk about health systems in fragile settings, what characterizes those. We're going to then dig a little bit deeper, specifically into eHealth, and then give a couple of examples of employment of eHealth, specifically low-cost eHealth solutions with a case study in Lebanon. So to start off, there have been actually, interestingly enough, very few definitions of what is a fragile setting. So the definition that is most commonly used is that a fragile state is that of a low-income country characterized by a weak national capacity and legislative defection, which makes citizens, and I would add to that, as well as refugees, vulnerable to a range of shocks. Now, although this is an interesting definition of fragile settings, I am sure that many of you can expand on this to include many countries who already, although their legislative or national capacity is good, they can still be thought of being fragile. Now, worldwide, here are a few figures. First of all, around 2 billion people. So we're talking about 2 out of 7 billion, so 25% of the world's population live in fragile or conflicted affected settings. Now, the scary part is that this number is expected to increase to around 3 billion in 2050, with the majority of those contexts being either in sub-Saharan Africa or in the Middle East and North Africa region. And I think that most of you would have expected that the sub-Saharan Africa is known for, weak, central government structures. Many of them had also armed conflicts, and there's a whole issue of also level of income. The Middle East is globally known as a hub or a center for humanitarian crisis. It has been the case for more than 70 to 80 years and continues to be the case. Now, interestingly enough, although we tend to equate fragile settings with low income, half of those countries considered as fragile are actually middle income countries. And of these, of the extremely fragile contexts, which are 15, 9 out of 15, which is easily more than half of those, are in active armed conflict. And hence, these are examples that you can see on the slide. So we're talking about Afghanistan, the Central African Republic, DRC, Congo, Iraq, Mali, Somalia, Syria, South Sudan, and Yemen. Globally, this is an interesting figure from OECD because, again, for most of us, whenever we think about fragility, we think about governments, big governments, we think about armed conflict, but the OECD has expanded a little bit the definition to say that it does not only include those dimensions, it also includes an environmental dimension, which is very interesting, as well as a societal one. So all of this just to start sharing with you that the issue of fragility is much more than what you had imagined when thinking about states and health systems to be discussed now. So what about health systems in these contexts? So first of all, the biggest problem is the issue of fragmentation and scarcity of resources. And that is associated closely with the lack of a central government. The second is the issue of lack of skilled and trained healthcare workforce. And that happens because of two reasons. The first is that the system itself does not have the infrastructure to generate skilled and trained health workforce. So this is reason number one. But reason number two is also the trained healthcare workforce who would have been in those contexts, in those countries, would probably, as a result of the fragility, would migrate out into better contexts. So these are the two reasons. Thirdly, is the issue of safety. And we have seen and read quite a bit in the past few years on the issue of, in many contexts around the world, attacks on healthcare facilities and how that has been detrimental to the delivery of healthcare services. And lastly, and this is the end game, and this is where it touches the end users, where as a result of all previous three, there's a limited access or a compromised access to the delivery of health service and to the receipt of health service. So basically, whenever we're talking about a health system in a fragile setting, we are equating it directly to the lack of access to healthcare services, not even mentioning the quality of the services delivered. So basically, these 6 priorities, which tend to have some common elements with any disease profile of any population, but there are a couple that are important. So we put mental health disorders as the first because what comes with fragility, especially with armed conflict, is quite a bit of mental health disorders. And we've seen that in many countries, and that remains a big challenge that for most healthcare systems in those settings, they do not have the capacity to deal with this. Because in many instances, their priorities are not on mental health, but rather on clear issues related to healthcare. The second is communicable diseases, and that is natural because in many instances, what's happening is that there are, little wash services delivered. There's the issue of lack of vaccinations and so on and so forth. Traumatic injuries for obvious reasons, especially in armed conflicts. OB-GYN conditions, because unfortunately women and children are a primary, victim in these settings. Malnutrition, again, because of low income, because of lack of access, the ability to provide even support, even assistance to these contexts. And lastly, NCD. And NCD is an interesting category or condition because in our dealings with fragile contexts, interestingly enough, especially when it comes to hypertension, diabetes, even cancer, folks stop viewing these as a priority, and they are more interested in dealing with the urgent matters, acute illnesses, rather than non-communicable diseases, because in their mind, if they do not take their medications or take good care of themselves for the next 6 months, 9 months, their disease would still be controlled and have an effect beyond that, which is an interesting finding that we were able to detect, and at the same time, a scary one. Now, the question is, with all of this, how do we marry or couple health systems in fragile settings with eHealth? Because for many of us, for many actually around the world, their thinking is that whenever you mention eHealth, they're thinking about something that is really expensive, high cost, ability to deliver is dependent on strong infrastructure, and so on and so forth. And that is the case in many incidents or many instances. However, the beauty about the technology that has expanded in the last few years is the ability to capitalize on it, even in a sort of a low-cost approach, and we will discuss some examples. So these are the definitions of eHealth, and basically the one that I like the most is the shortest and the simplest, which is health services and information delivered or enhanced through the internet and related technologies. So examples of eHealth solutions, and these are some of the domains or aspects of eHealth that are gaining quite a bit of traction. The first is mobile-based interventions. And this applies in fragile contexts because, interestingly enough, and many of you know that, is that even when there are armed conflicts, when there is low income in a country, the level of penetration of smartphones remains quite high. You would go to, deserts or places where any sort of infrastructure is absent, yet you still are able to find someone with a smartphone, which is very interesting and something that the whole healthcare system need to capitalize on. Telemedicine is gaining also quite a bit of traction, especially in two settings. The first is when it comes to rural health delivery and also to underserved health delivery, linked to what we have said earlier, with less and less healthcare workforce in these areas. What you need is the good doctor to be present in that location, remote location, underserved location, without physically being there. And telemedicine definitely is becoming low and lower in terms of cost, and more in terms of need. Electronic health records to this point is quite an expensive undertaking, except in certain conditions, and we will give an example on how it can be a low-cost intervention or eHealth interventions. Wearables are now quite common in developed countries. They are less available in developing countries, but they're gaining a little bit of traction. But still, the whole culture around wearables is not as mature as not as mature in fragile settings. GIS, Geographic Information System, is another example. And this is mostly used for data and planning. And again, we have seen examples of the use of GIS in many African countries where the context helps and where this has been a good planning and cost and resource allocation tool. So why eHealth? So there are 4 main reasons why everyone who works in health systems, or be it health systems planning, management, or what have you, should be interested in or explored or intrigued by eHealth. The first is that it has quite a bit of potential when it comes to cost savings. And what will happen is that as resources become more and more limited, then there would be the need to become more innovative with less cost will increase. And definitely eHealth is a platform that would fit that criteria. Secondly, studies are showing more and more that eHealth improves both short and long-term health outcomes as a supporter to traditional delivery of health services, but in some instances also to replace it. Third is the increased equitable access to health services in remote areas or the context of displacement and fragility. And this challenge has not been unique only to developing countries, but also to developed ones. So in many developed countries, the issue of a rural versus urban divide is very pronounced and has been a challenge for many, many years. That's why there's a whole discipline that is rural health. And lastly, to overcome some barriers of access. I would call these barriers, I would call them as logistical barriers, especially the issue of transportation, lost time, and so on and so on. So with all of that background, I'm happy to share with you a couple of examples on applying eHealth in fragile settings. And both of these examples were implemented in Lebanon. And why Lebanon? One, because more than 1.5 million refugees, so the slide says refugees, but it's million refugees reside in Lebanon. And actually, this is the formal figure. So informal figures put that at around 2 to 2.2 million refugees. So this is in a country where the total population is between 4 to 4.5 million. So we're talking anywhere between 1/3 to 1/2 of the population is refugees. So I always give that example to our friends in the United States, where I say the United States has around 3 to 320 million population. And I say, imagine that you have an influx of 100 to 150 million, just to give you a scale of how big of a problem or a fragility context this is. So the health system is overstretched because even to start with, the surge capacity of the health system in Lebanon was rather minimal. Fourth, it's surrounded by countries that also themselves are subject to protracted crisis and conflict. The most perhaps internationally recent country is Syria, where the conflict has been happening since 2011. And lastly, the political instability that I'm sure many of you are hearing more and more about in the news nowadays. Add to that, very recently, the issue of economic instability. And I think this will, in the next few years, will even get worse. And this is something that worries definitely many Lebanese and should also worry many around the world because of the burden of refugees. So the first project that we will discuss today is called the ISAH Project. And Saha in Arabic means health. So this is the first, or let's say among the first mobile health mHealth projects in Lebanon. It was supported by IDRC, the International Development Research Council of Canada, in collaboration with the Ministry of Public Health in Lebanon and UNRWA, which is the United Nations Refugee Agency specifically for Palestinians. The intervention was an SMS-based intervention. It specifically targeted those individuals either with diabetes or hypertension residing in rural or refugee settings. So the reason we wanted to do that is because we thought it would be an interesting comparison to see whether refugees, specifically Palestinian refugees, who have been in Lebanon for 70 or 80 years and are disadvantaged both economically and socially, just simply because of the refugee status, socioeconomic, and so on and so forth, whether those, when it comes to health, they can be equated, for a lack of a better word, with disadvantaged Lebanese. So the intervention had two components: a community-based intervention and a PHC center-based intervention. For community, what we did is we did a community screenings that was done by field workers, and the data entered directly into a netbook application. And we have designed actually a sort of a low-tech, low-cost, but very effective, if you say, algorithm or model, where on the spot, as the data was being entered, the model would flag based on an algorithm, predetermined algorithm, whether that patient is actually might have diabetes, undetected hypertension and needed referrals, or whether they already knew that they had diabetes and hypertension but have failed to be in touch with the healthcare system for some time. So that's the community-based intervention. So again, it enabled us as a project to increase access through early detection using that mobile application, or through lack of follow-up and giving a little bit of health promotion and education to patients. Now, on the other side, the supply side, part of this, it was based on SMSs. So that SMSs, we worked with the primary healthcare center, both of the Ministry of Public Health and UNRWA, so that through pre-designed SMS messages to be sent directly to the patients of those centers, not only providing weekly medical information. So just to give you a simple example, if it was the summer where it's the season for fruits, then we would provide, or the messages would include information about a person with diabetes, how much fruit intake should she or he have, if somebody is pregnant and has diabetes, how she should take care of her pregnancy. And in addition, we worked with the centers so that we have targeted SMS that included reminders of appointments and regular follow-ups. So that is one component. The other component is we help those centers in automizing their schedule system, which is a simple task, but would help with the earlier one. So once the scheduling system was automized, it helped with reducing redundancy, reducing inefficiency, and again, it was a low-cost intervention. So this was the intervention, and basically that resulted in, so far, in 3 publications that I think the link for the publications are available in the message section of the webinar. But to highlight few numbers that may be of interest to you. So we were able to screen around 3,500 individuals, and of those, 26 were from 5 rural areas, around 1,000 were Palestinian refugees, and we have generated around 300 referrals to the nearest PHC follow-up. So these were either folks who did not know that they may have diabetes or had diabetes but were not following up. And interestingly enough, as a result of the intervention, and this is available in the published papers, we saw improvements in blood pressure control, systolic blood pressure, as well as an HbA1c, which is related to diabetes. Now, the drop in HbA1c was not huge, but it was still significant based on the data. So this is the first example. Now we're going to give you a second example. This is, as people say, the crown of the jewel when it comes to what we have done over the past 2 years. This is a project that is called Sijilli. Sijilli in Arabic means my record. And basically, the idea came that in many instances, especially in armed conflicts, interestingly enough, one of the few things that people who leave their countries or their houses take with them is they take with them the keys to their house. Although shortly thereafter, there wouldn't be a house left for the key, but still it's an emotional attachment. So the idea came is that what is equally important to their attachment to their home is their attachment to their health. We have seen the examples of the many cases where, and the pictures that we have seen of people dying during their migration journey, whether drowning in the sea, getting to countries where the healthcare providers do not understand the language, do not understand the culture, and as a result, there has been many health-related challenges and access. So the idea came on, why don't we design and offer and test a system where the electronic health records, be it a simple one, just have be mobile, meaning wherever this person goes, he or she will have their electronic health records with them. And they will have it in 2 ways. The first is that through a USB that we have, we developed based shaped as a key. And the second is having it through the cloud, meaning that if the person lost that key, then she or he will be able, wherever they end up in the world, just saying the word Sijilli, and then the provider would just Google the term, find Sijilli as the first hit in their, I say Google, but whatever it is, the search engine, find the first search as Sijilli, click it, and then there they are with a username and a password. They can have access to electronic health records. So just imagine with us a refugee who starts in Congo and goes all the way to a different country, all the way to North Africa, and their path to say they want to migrate to Europe or to Canada or to the US or to Egypt or wherever. And all through this journey, the woman, the child, and the man will have their electronic health records with them. So just imagine what would the result be in terms of improved access, overcoming cultural barriers, and as they move from one country to the other, the Sijilli would allow them to, amend that electronic health record if the provider has a valid license and so on and so forth. So we're happy to share with you that We have completed our phase 1 target, which was 10,000 refugees. So now there are 10,000 Syrian refugees who reside in Lebanon who actually have Sijilli. Our next goal is 100,000 refugees, and hopefully we'll start that soon. But we have finished the first phase, and we are very, very proud that this has happened. So what I'm trying to do now as we speak is I'm trying to hit the next slide, and it's not working. So what I'll do is I'll stop sharing and I'll do it again. Okay. So the features of Sijilli are the following. The first is having multi-layers of security. And this was extremely, extremely important for us when we designed the architecture of this, because the refugees have especially vulnerable status when it comes to the issues of security. So it was very important to add multi-layers. So that includes username, password, random questions that are pre-built into the system that the user herself or himself pre-entered with their answers. So this was very important. The second is the cloud-based component. The third is being able to retrieve the health record online and not only through the USB. And fourthly, is having this be functional all around the world. Now, we have to be honest with you that the startup cost was quite significant. Now, what helped is that we were able to secure a partnership with a private company that is Epic, one of the leading electronic health records company, who actually provided all of that support in kind. But from there on, from that development of the architecture, from the infrastructure, the operating and the running cost is actually, it's a low cost operation. It just needs, partnership with implementing partners on the field, which we had. And this is a model that can be replicated anywhere in the world. So what happens is we have primary data collection happening. Most of those who did the primary data collections are actually volunteers. They are medical students, nursing students that we have trained, and they were happy because this is a project where part of it is community service, part of it is them gaining experience. Then there is access to Sijilli through either the USB or access the Sijilli through the model. Then wherever they are, even in places where there's no connectivity, the system stays there, and whenever the system gains access to the internet, then it syncs it with the cloud. But the download, the thing that we did is once the data is entered and they press the submit, then the data is de-identified. And whenever the data is not even downloaded from the cloud, it's also de-identified. So we have no way of knowing who that person is. Only that person knows and is able to access their records. And the access is done through a web page, both in Arabic and in English, either by the healthcare provider or the patient themselves. So to know more about Sijilli, the clinical and technical design and implementation, we have a completion event happening on March 3rd at 4 p.m. Beirut time, and this will also be followed by the third live webinar of this series. So we look forward to having you join this and learn more about the experiences of doing Sijilli. We were able to published that as well in Lancet Global Health. So this is the first article of the series, and if you're interested in that, it's you can Google it. It's published in Lancet Global Health. I think, thank you so much. This is the end of my part of the webinar, and I think now it's open for Q&A.
Thank you, Dr. Saleh, for this very timely and comprehensive presentation. We're opening the floor for questions. So for those of you who would like to ask questions, there's the Q&A icon. You can go into that and type in your questions. So we have 2 questions so far. One is a comment, actually. So the first question is, what are wearables? And the second comment is, surgical conditions also should be addressed along with obstetrics and gynecology. And these are the questions that we have so far.
So wearables are mostly the models of the iPhone, the Apple Watch, the Fitbit. So these are more and more of these are being developed, where you put either on your wrist or on your neck, and what they do is that they help in assessing how you're doing in terms of blood rate, heart rate, in terms of physical activity, measuring your blood pressure during the day. So these are the wearables. As far as surgical procedures, that is also true. This is also an aspect that is included and is one of the high priorities within fragile settings. And I think that most of those may be under the traumatic component that we discussed.
Okay, perfect. So we have 4 more questions. The first one is on what is the role for entrepreneurs, private companies in developing these solutions? The second question is on what was the startup architecture costs for Sigilli? And the third question is on what would you shed more light on the identification process to protect privacy? So we have many more questions coming in, but I think we'll take the first 3 questions for now.
So the first of all, the private companies or the private sector in general has a huge role to play in this. Now, the question is the level of competition. So forget about developed countries, right? Or forget about, because now we're talking about fragile settings. In fragile settings, the private companies can intervene in 2 ways. The first is through developing more and more low-cost technology. And secondly, for private companies who are in it to make money, whenever they are working in fragile settings, they would avail that technology for, community service or as part of their CSR. CSR stands for
corporate social responsibility.
Corporate social responsibility. So what was the second question? What are the startup architectural costs for Sigilli?
Yes.
Okay, they were quite significant, and the good thing, this feeds into the first question, which was the costs, which if we were to monetize would be quite significant, were provided by Epic as the as the partnership component with the Global Health Institute for Sigilli.
Perfect. And the third question was, would you shed more light on the identification process to protect privacy?
Okay, so let me take you through this step by step. The first is, once you enter the data, what happens is the minute you press submit, even if the data stays locally on the notepad, the data is de-identified. This is one. Once it's connected to the cloud for the upload, the upload happens in a de-identified way, second level. Thirdly, when we want to download the data for, say, analysis, the data that gets downloaded is de-identified. So we have no idea who is it, whose data we're looking at. Now, additionally, for the patient herself or himself, when they want to access their data, there is the username, the password that they have identified, but also in addition, the system asks them a security question, you know. So it's very similar to when you want to access your bank account or Google account or Gmail or what have you. That security question is an additional layer of security. So all of these were put on the system because we know that refugees are a vulnerable population, and we want to, as much as possible, maintain that. In addition to all of this, we did encryptions on all levels of both softwares and hardwares.
Perfect. So we have 10 more questions. So maybe shall I take them one at a time? Do you prefer that, Dr. Saleh, or do you want me to list 3 questions at a time?
Let's do one at a time, because I know that we have to stop this at 5. So I'll do short answers.
Okay, perfect. So with you addressing the wearables, do you think people in developing countries are able to afford it, and any initiatives to provide these?
So the answer to this is wearables. The good thing is wearables are getting less and less expensive. So I would assume, as was the case with mobile phones, that within, I would say, 5 to 10 years, that they will be accessible in low-cost settings. Are we providing this at this point or using them as part of our eHealth initiatives? Not yet, because they're still a little bit more expensive than what we classify as a low-cost intervention.
Next question, is Sigilli open source?
Is Sigilli open source? I do not think, no.
What advice do you have for a PhD student that is looking into creating an e-intervention for refugee population?
First of all, the issue of security, definitely, and just think simple. You know, this doesn't have to be, it's the idea that has to be novel and not necessarily the technology.
Do you see opportunities for artificial intelligence and machine learning for eHealth in fragile settings? Are there any examples of AI already being used in these settings?
So interestingly enough, Amit just who asked that question, we are happy to report that we have just been approved for a 3-year project to use both gamification and artificial intelligence to enhance access in fragile settings. So we will be reporting on that, I'm guessing, in a couple of years. I know too late for you, but it's, you know, it's coming, yes.
When do you think electronic health records can be implemented to all Lebanese, and what are the main challenges that delay this implementation?
It will be, it wouldn't be anytime soon. The main challenge is fragmentation and interoperability.
So for the ISAH project, how much was the project acceptable by the participants?
It was quite acceptable, because what we did is we have worked, it was mostly participatory research. We have worked through communities and through the PHCs and through local community leaders, and hence that's why the acceptability was, you know, was quite high. And there's actually one paper that reports on user satisfaction out of the 3 papers.
So quite some questions coming in. So can you please explain how can the eHealth be used in malnutrition?
So eHealth can be used in malnutrition, again, through building also, simple algorithms that screen for malnutrition and have health education, health communication, disease prevention component to it.
So this is an interesting question, and we have kind of a follow-up question that came in through emails. So does Sijili have disease surveillance capabilities? And we received a question over email asking us about how this could potentially be used for the control of pandemics, for example, the current coronavirus.
So it cannot be used for pandemics because unless Sijili becomes the mainstream electronic health records among, say, refugees in a certain area. So we have done the infrastructure. What we are trying to do now is working with the providers to try and be accepting and have Sijili be more and more of a mainstream platform to detect diseases. So if that's the case, then probably it can be used for, say, surveillance as well.
Is there any current activities towards mental health in fragile settings?
Yes, as the Global Health Institute, actually, not necessarily the eHealth program. The Global Health Institute have a couple of projects specifically on mental health and fragile settings. So I would encourage all of you to go into our website and to check those out.
I think we will take a couple of more questions. So what are the barriers of using artificial intelligence and eHealth?
I would say one is cost, but what also is of a great, I should say, importance is the issue of maintaining security of the records and being careful in how to use the data that is being generated.
Perfect. So how do you make Sijili sustainable?
You make Sijili sustainable through working more and more towards health systems being accepting of Sijili as the new modus operandi, because it's cheaper, it's mobile, it doesn't require as much infrastructural costs and as the systems that are currently being available in many current countries around the world.
And so I think you've answered this question. So there was a question around accessibility of Sijili to developing countries and to patients that are in remote areas in Lebanon. So whether will they be facing issues of accessibility, of access?
What I'm not sure that I understand the question. So if
Yes.
Saho can ask this again, it will be great.
Yeah, so the developing countries are still striving to get to remote areas connected to the internet. Any alternatives to solve this?
Yes, so the neat thing about Sijili is the data can be completed totally offline, and whenever there's a connection, even in few days, then that data can be uploaded. So you do not need internet connection as you're doing this.
Perfect. I think the last question is on what cloud is a new, does Sijili, so is Sijili cloud-based? I think this is what the question was, and I believe you've addressed this. And the last question is on, is there governance capability to manage payments and medicine supply?
No. And that was never the intention. Our intention is just to provide refugees throughout their migration journey and even when they end up somewhere and settle, with the ability to access their electronic health records anywhere, whenever, wherever, without being faced with language barriers, culture barriers, recall barriers, any of this.
Perfect. And I think just one last question. So do you think Sijilli can be adopted or adapted by other fragile states?
Absolutely. That is one of the main reasons we did that. Sijilli is a model that can be implemented anywhere in the world.
Perfect. Should we take one more question or?
Yeah, sure.
Okay, so is there an appetite within the medical community to use Sijilli?
The more we are educating, for a lack of a better word, educating the medical community about Sijilli, the more they see the utility of having it and its relevance to the refugee population. Actually, I think next week we are organizing or co-organizing with the Ministry of Public Health in Lebanon a workshop with 20 to 25 primary healthcare centers in Lebanon to tell them more about Sijilli and how it can be used. And we will leave it up to them. This will not replace any electronic health records that the country wants to adopt. It will just supplement, make it easier, and make it more accessible.
This is an interesting question. So Ruba from Nigeria is asking, are there any initiatives or ongoing discussions to implement Sijilli in sub-Saharan African countries?
So our focus, Ruba, has been so far is to do the proof of concept. So with the finalization of the 10,000 records, we have already done that proof of concept and proved that Sijilli as a model, both technically and operationally and logistically, can happen. So now is the phase where we can start discussions and expanding Sijilli into other parts of the world, especially in fragile settings.
Perfect. So thank you so much, Dr. Saleh, for this great webinar. I just wanted to mention that we have 2 more installments for this webinar series, one on February 25 and one on March 3rd. So I'd like to encourage you all to sign up for these webinars, and you will be receiving the recording along with a survey after the webinar. Thank you so much, everyone.
Thank you, everyone.